It's my pleasure to introduce from the AHA Weedy board member, Terry Cunningham.
Thanks, everyone. As Michael indicated, I'm Terry Cunningham with the AHA. On behalf of the Weedy board, I want to thank Itiliti Health, both for being a sponsor of Weedy, as well as for this informative presentation that you're about to hear. In this presentation, you're going to hear about, have a look at a live demonstration of a unified prior auth platform designed to kind of simplify a lot of these complexities that we've been talking about this morning. They're also going to walk through the value of centralized policy ingestion, seamless versioning, and automatic questionnaire creation. So without further ado, I want to turn it over to Michael Lesner and Keith Brick.
Hello, thank you. I'm Michael Lunzer, CEO and founder of Itiliti Health. Really appreciate the opportunity to talk with you about our topic today, which really is honed in on really focusing on digitizing medical policies. I'd like to also introduce Keith Brick. Keith, do you want to talk a little bit about yourself and introduce yourself?
Certainly. You've perhaps seen me at some of the HL7 Connectathons. My passion is helping everybody adopt a standard that works, meets the needs of your clinicians, your patients, and today we're talking about your policy administrators. So my goal is to help all of you understand the technology that's available within the marketplace, within Itiliti Health's platform, to take your policy and match it up with what the EHR has available. And ultimately, make it so that when a provider needs to fill out questionnaires, it's never double entry, it's only entering new information. And ideally, they don't have to enter anything at all. So we'll talk about how to get there, and back to you.
Thank you, Keith. What we'd like to talk, no, it doesn't want to give me the automation here. That's all right. Go. In terms of policy digitization, we like to talk about our presentations in terms of what are the questions that you'd like to have answered or that we commonly hear people asking. And these are really the outcomes of our presentation today, is helping people understand, do I need to rewrite all of my policies? And if so, why or why not? Is EPA viable without highly codified automated CQL questionnaires? How do I include the challenge of policy digitization within my workflow? We talked a little bit about that in a panel a few minutes ago. What role does AI play in this process? And then how do third-party criteria and policy guidelines fit into the overall picture for DTR? So we'd like to start by just talking briefly about what are we trying to accomplish with all of this. And I think it's really important to keep this in context when we think about what we ultimately want to deliver and need to deliver shortly. Obviously, providers are really frustrated with faxes. And one of the things that I like to think about is the common attribute of faxes. Why are providers so drawn to faxes? It's because it's a common method of operation. They don't have to think about where they're going. They can easily just pick up a phone number and they know how to do it, right? There's no confusion. The evolution of portals has been great from a payer perspective because they help us get more structured data. But again, there's a lack of a common method, and that's what really frustrates providers. EPA promises a common user interface, a lot more clarity around what is required, and ultimately a faster process. So I like to think a little bit about what the challenge is for the provider today and why DTR and CRD are so important, and ultimately why they use faxes. If you think about it today, when a provider goes out to a payer system, they need to perform a procedure, they have to go find this information at the payer's website. Does it require a prior auth? It's usually buried in a big spreadsheet with 4,000 rows. Where do I submit the PA? If you've got delegated vendors, is often buried on a web page. And then if I want to go find out what do I need to submit and what are the rules that I'm going to be held to, I've got to go out and look for a policy that also is buried in a web search on the health plan's webpage. So the promise here is that CRD can offer an instant answer to that is prior auth required, and DTR can present an instant answer to what's required. Ultimately, in this equation is also bundled in, where do I submit my prior authorization, opportunities for attaching documents or answering questions. So now we get to the big challenge. From a payer's perspective, I've got hundreds of policies and I need to find a way to convert those policies into a codified language. I'd like to look just a little deeper into what that process is for a payer today. Kara mentioned this earlier. Payers create these policies in Microsoft Word. A committee creates the policy, then they go through and approve that policy by sending it around to a committee. Once they finalize what they've decided is going to be the policy for a particular procedure, that policy then has to go to a website team, and that website team has to take that policy and load it into the slot that the previous policy existed in, somehow archive the policies, add some method of effective date to that policy, and then ensure that they've tracked the history of the old policies. So, obviously there's some big challenges when they're doing this process manually. How do we keep track of versions? Where do we keep the archives? How do we make sure that these policies that are in are the approved policies versus a draft policy? How do we audit this process? Usually, again, it's manually people loading up a new policy. And of course, that drives a real big problem with efficiency. And now those policies in most health plans are typically loaded up in a document store on the website for the health plan, which makes it really difficult to find. It's human readable. And now when we've got DTR, we have this totally digital process married up against manually created human readable policies. So how do we bring these two worlds together? And also, when you think about the challenges of this process today, are there some opportunities as we bring these processes together to simplify the process and make it more structured and more normal as compared to what you think about with technology today? So the real opportunity is to put a system in the middle of this process that allows us to codify policies, put them into a human readable and a machine readable format, kind of deconstruct them, if you will, manage effective dates and details that are common between policies, and then easily make those human readable policies immediately available from their technology source, rather than having to move policies around from one system to another. That codified documented system or database of policies can now feed the machine readable experience as well. So this is one of the big opportunities to add efficiency to the process.
Yeah, and I'd love to talk about when we're thinking of building a new source of truth for this policy database, our goal is to put it directly into the provider's workflow and to make it a live connection so that now when that policy goes live on your website, it is simultaneously answering that question of, is authorization required? What information do I need to submit? And so having that new source of truth be both your written policies and your computable policies is, I think, a really important part of this process. And then CRD is that mechanism under the CMS 57 APIs where we can then put it directly on the provider's desk or on their screen in front of them.
And just one example of where this data becomes fragmented in a non-technical world is oftentimes the health plan has their CPT codes that require prior authorization in a spreadsheet. And then also on the human readable version of the policy, there are CPT codes. So there's a need to manually sync those two. It's just a really inefficient approach to this process. So if we can unify this data into a system that helps manage, the creation, the approval, the editing, the versioning, and the transparency, both for humans and machine readable documents, that's really the nirvana that we need to get to. And I think when we talk about policy digitization, it often revolves around codes and JSON and FHIR, but really it's important, again, to go back to the source of where is this data coming from, and are there some big efficiencies we can gain from re-engineering the process. So now when we talk about the actual policy digitization of the guidelines, because that's, I think, what a lot of people think about when they think about digitizing policies. We have a goal ultimately in this standard of digitizing policies and the guidelines, getting them into a format in CQL with codes associated with them, such that when a DTR is sent over to a provider, it's all automatically entered and immediately transacted, and there are approval rules associated with those guidelines. And that's, of course, the goal that we all have. So there are a lot of ways to get there. It doesn't have to be a revolution. It can be an evolution. As we see people in the marketplace, there are some organizations that are taking AI and loading in a 10-page medical policy and asking AI to give them a list of questions and the appropriate codes. And we've seen that that can be effective, but as a procedure within a health plan that has spent years building out medical policies and verifying those policies, it becomes a really risky proposition. Is that policy questionnaire going to equal the policy questionnaire that is available in human readable form and is a vehicle that has been proven over time?
Michael, you talked about CQL. I have an audience participation question. Raise your hand if you know where you can get a FHIR authorization before DTR. All right. I am too nerdy for this topic. I know Michael knows. So in the CRD request, the EHR will actually give you a token, a FHIR authorization that says you can use this to come back and pull whatever FHIR data you need in order to guide my provider to the right portion of the policy. And what's really cool is that if you write your policies creatively and ideally, you can go and fetch from the EHR every single thing that you might need to place the patient into that right criteria. If their BMI is a qualifying measure that you need to know, you can get BMI. It's got a link code. It's a FHIR resource that you can retrieve. It's an observation that you can find in the patient's chart. And oftentimes, what that means is that a well-engineered or well-written policy might only ask the provider one question, which is, hey, there's 2 ways you can perform this procedure. Which way would you like to perform it? And it can be really that easy. That's the vision that we're working towards. And the reason I mention this is because right now, CQL is complicated and it's not broadly adopted. If you go out to a health system and you say, hey, I want to run this CQL package against your EHR, their EHRs can't do that today. But they do have the US CDI FHIR interfaces. Those resources are available for you to go and pull immediately as soon as they send you a CRD request.
Thank you. I think the key message there is, there is an evolutionary relevance to this process. It's not as simple as converting all of your policies into codified CQL questionnaires. Another pathway that health plans take or have looked at to get to CQL-based questionnaires is to manually rewrite their policy guidelines into a full CQL taxonomy. And as you can imagine, that's a really big task. A third process is to convert those questionnaires into some form of questionnaire that has minimal text changes, but still allows the provider to quickly know what's required and maybe check boxes to say yes or no, I meet this requirement, rather than providing the answer to a BMI question, for example. This approach allows the health plan to incrementally adopt new standards. So they can convert a questionnaire, an existing policy guideline, into a CMS 0057 compliant DTR without having to convert a list of requirements into what many people think of as a question. And I think that's one of the key elements here, is that when people think about a DTR questionnaire, they use the typical English version of a question. The reality is these DTR questionnaires are really intended to be an information gathering experience. So it doesn't have to be a question. It can be, please indicate if your patient meets the following requirements. It can be as simple as checkboxes. That approach allows you to incrementally convert your existing policies into something that's DTR compliant rather quickly, without having to go to the extreme of codified questions and clinical measures. And there's a big opportunity there, because it allows us all to get from where we are to where we need to be using FHIR, providing providers with information about what's required without having to have this huge lift of clinical questionnaires associated with each guideline. Do you want to talk a little bit about that evolution and what we've seen in some of the Trebuchet groups and some of the other standards groups, with people looking at that as more of an evolutionary approach?
Yeah, absolutely. So like I was talking, in the adoption of CQL, we know that the vendors, the EHR software vendors, need time to implement that technology. We know that on the payer side, payer organizations need time to codify their policies. And so where do we meet in the middle? And the answer is, well, let's stand up the APIs, let's put in the plumbing, and let's turn it on with just a trickle of requests and say, okay, is prior authorization required for these policies that we know are easily computable? All of them want the same information. They want to know, what are the patient's diagnoses and comorbidities? They want to know, what are the patient's primary vital signs? What are their basic things that are already recorded in the EHR? Let's get that information, because that's going to inform whether they're eligible for these commonly ordered procedures. And so hitting that low-hanging fruit and using the FHIR data that you can immediately pull from the EHR can get you, for a surprisingly high percentage of the volume that you're receiving faxes for today, you can get that all answered electronically just by setting up those very simple questions and letting the EHR answer them using the technology it has today.
So what this means in practical perspective is our customers codify their policies, move them into a digital CMS 0057 compliant format, and all of their policies can be converted into that format in a short period of time, because essentially we're utilizing the existing criteria as the form that's used for the questionnaire, and they can assign more complex questionnaires across multiple policies to gather the codified data that helps them to begin to gather more structured data against those requirements. Ultimately, getting all of the policies converted into a DTR compliant format allows the provider and the payer to transact using 0057. It gives that provider one common place to go for all of their payers to know what's required, what do I need to submit. By the way, a DTR compliant questionnaire can ask for documents. So it doesn't have to just be a question. It can be, please attach the document that provides evidence of this particular condition. And so there are some really easy ways to become compliant with policies and then begin building the perfect future of CQL-based policies that are what we all think of when we think of really highly efficient coded CQL questionnaires. So as our health plans implement this, we recommend they convert all of their policies to a DTR compliant questionnaire and then begin to implement more complex CQL coded questionnaires for those commonly used procedures. But that will also allow their providers to start to give feedback as to how well those complex CQL questionnaires work. There is a risk that if all we have are complex CQL-based questionnaires, providers may not be able to really use that. And as we've talked about earlier, it's really important that we get adoption. So the Itiliti Health approach to this process, again, we have a product that ingests the entire medical policy from a payer, creates a more organized process for managing and editing those policies. We extract those policies into multiple segments. So if you think about it, most payers' policies have specific headers and a standardized format. We ingest all of that information into our system. We also ask the health plan to configure the required documents that they want to see for each policy. And that helps to somewhat mirror the existing process where providers are faxing documents, but also ensures that at its common, simple form, the payer is getting all the information they need to make decisions and not having to go back to the provider and ask for more. So I'd like to talk briefly about a case study. This is a fairly large health plan. They had 600 medical policies. Those medical policies were formatted in Word and PDF format. The ingestion process, we spent 6 weeks looking through all of their policies and making sure we have common formats. Turns out they used a couple different formats, so we had to codify the ingestion process to recognize those different formats. We ingested those policies, and when that took place, we carved up those policies into different data elements in the database. That allows our system to then have a machine-readable companion to some of those components. So for instance, if the policy has a coded list of all the procedure codes, we can separate those procedure codes out into individual database elements. And then when somebody wants to view a policy, we dynamically recreate the policy so that it looks exactly the way it used to look when it was a PDF document, but now it's made up of multiple segments of data, some of which are very highly used in the machine-readable environment.
And when that CRD request comes in, they're providing a patient resource, a coverage resource, and a procedure request that contains that CPT code. And so now, because we've ingested that policy, we've mapped it to its CPT codes, we can go and retrieve those exact database elements that will satisfy the CRD response. And it's tied directly to that policy, so it's a real-time match.
So now that CRD response not only says yes or no prior auth is needed, but it also says which policy applies to that procedure. And within this same policy system, we also recognize that there are a number of policies that are provided or managed by third parties. So we also accomplish the connectivity to an MCG or an interqual policy through that same policy management system. I just wanted to show you a few artifacts that come from that implementation I talked about a minute ago. So from the health plan's public website, if you go out and look at policies, you get to a screen that looks like this. This page is hosted by Itiliti Health, and it has various ways that you can search for a particular policy for a procedure. You can enter in free text, you can enter in a procedure code, you can go look at specialties, and you can pick the date, the effective date. So for instance, if you want to go back and look at a policy that was effective, the policy that was effective in 2023, we can go back in time and find the right policy for that date. So again, if I pick a particular policy and view it from that system, it looks just like it did 6 months ago. The reality is in the database, it's made up of multiple segments of data. Within the Itiliti Health administrative system, you can then see all of those different data attributes that come out as separate items that make up that policy. And again, within that list of items, you'll find criteria. When we look in the criteria or the guidelines, we have a human readable version of the guideline and a machine readable version of the guideline. That machine readable version of the guideline can of course feed DTR and look very similar to the criteria that used to be human readable, but be presented to that provider as a questionnaire. So they can come in and answer yes or no, the patient meets this requirement. They can attach the appropriate requested documents and submit a prior authorization in a way that's extremely similar to the way they've done it before on the portal, but we've moved everybody all the way over to FHIR. And now we can enhance these questionnaires to become a much more CQL coded type of questionnaire where the data is answered automatically. But it's done at an incremental phase. And this is really important because as we've spoken with payers, most of them are really concerned about how am I going to convert all of my policies into this DTR transaction in the timetable that I'm allowed.
Can I
Again,
go back to that one real quick?
yeah,
I want to show, I just want to call it, if we think about the fax forms that we're receiving for lumbar fusions today, those fax forms have a big chunk at the top that are the same questions on every single one of your inbound forms. The patient's demographic data, the patient's primary care provider, the patient's coverage information. We don't need to request any of that information anymore. A provider doesn't have to type that in or fill it out on a piece of paper. You don't have to OCR it on your side. You don't have to spend money receiving a fax. It's all structured data when it arrives into your system. And when the system is reviewing it, now you can see what boxes were ticked. You're not trying to figure out a handwritten check mark. You're actually saying, yes, this data was provided. And if their EHR supports it and we can find the answer to this question in the EHR, we don't even need to show it here. In the provider experience, those questions vanish. It's already been taken care of.
so the last point I'd like to cover is those third-party sources of guidelines. So this is just an illustration of what the workflow looks like for an Itiliti Health customer. So on the far left, the provider EHR has requested provided a request for a CRD. It's going through a QHIN, a FHIR server, ultimately lands on Itiliti Health's PA checkpoint solution. PA checkpoint knows by CPT code, does it require prior authorization and which policy applies. At that point, if it happens to be an MCG policy, we're going to send back a URL to the provider for the DTR that helps navigate that DTR request back through that same chain. Itiliti Health is going to see it in our policy server, and we're going to proxy that request all the way through to MCG or Interqual or Evacor. At that point, when the provider sends the information in, we're going to do the same thing on that past transaction. We can proxy that data back to MCG for an auto approval, or we can send it on directly to the system for decisioning. So this is essentially what MCG and Interqual and Evacor and all of those third-party guideline companies seem to be endorsing as one method of getting that data all centralized into a common place that can answer, does it require prior authorization? What policy applies? Where do I find that DTR questionnaire? And then how do I get that information back to the right system? So that wraps up our presentation today. Just like to see if there's any questions. Yes.
Hey there. This was a great presentation. I have several questions. So what we're starting to see, it was interesting that you had the DTR kind of in the middle for the CDR to pass, because what we're seeing is the opposite, that, and it's really all over the board on how people are doing this. Some of them have is auth required as part of pass, but, what we're seeing is that most of the time you actually have to submit the authorization, and then they're sending back the questionnaire to answer the clinical questions once it kind of goes through the request process. I haven't actually seen that model, so I thought that was super interesting. Second is usually there's a timetable or a time box on how long that link will stay active. And is that something that you built into your model? And then my third question is, with some of these policies, they can get, there's a lot of things that can be involved with it. And one of the things that we're starting to see is the site of service. So an authorization may be required in the hospital, but not required on the ambulatory service. So is that part of your lookup? Because that's not just CPT code, it's not just policy, it's looking at other data elements to determine that.
Yeah, and that's in the proposed or the drafted service request or procedure that you're planning to perform. The FHIR resource can represent the performing location and performing provider. So for example, your provider might have a different NPI that they practice under. When they're at the hospital, that facility NPI or that separate TIN. And you can use that information because at the time of scheduling, when they're actually putting it on the schedule at the hospital, they know, okay, it's going to be performed by this surgeon in this operating room at this facility. And you're right, during the ordering process, like early on when you're trying to figure out how do I get my patient approved for this, you may not have that information, and the answers that you get from the algorithm are going to be, rather than yes, prior authorization is needed, or no, it's not, it could be, and it depends. It depends as part of the answer tree within the CRD step. And you're right, today, many providers are just going ahead and submitting the entire prior authorization form and faxing it in, because that's the only way to hear back, well, actually, you also need to fill out these 4 other forms. It's the most efficient way for them, because like Michael said, those other questionnaires that they would need to answer might be buried somewhere. And so they wait for the insurance company to come back and ask them to fill it out. And the way that we wrote the standard, I say we, the industry together wrote the standard within FHIR, is so that the CRD request provides the patient, the coverage, and the thing that you're trying to authorize. And then using that information, we can hopefully find enough of the details to say, all right, it does require prior auth. These are the questionnaires that you need to fill out. And only once you've filled those out, do you submit a actual prior authorization request. And importantly, you won't have to do all of that if you're gold carded, or if this particular procedure is always approved because the patient, has a particular BMI or has a particular comorbidity. And so we can save the providers so much work with that shortcutting. And that's what burden reduction is. It's no longer having to submit that entire form when it's not required. It's no longer having to fill in by hand details that the insurance company already knows or can retrieve from your EHR. I think I just got told we're out of time.
Yeah. So again, thank you very much for the opportunity to talk with you today. We'd be happy to answer questions on the side. We'll be here for the next 2 days. So thank you.
Thank you, Michael. Thank you, Keith, and thank you, Itiliti.